I'm excited to tell you about my work developing, evaluating, and implementing interventions for families with ADHD. And these are my financial disclosures. This is a book that we authored, which forms the basis for the studies that I'll be talking about today. And we've had NIH funding and some pilot money from the Your Mom Cares Foundation. The overarching goals of the work that we do in my lab at the University of Maryland are the identification of early, malleable, risk and protective factors which predict developmental outcomes for youth with ADHD. And we all know individuals with ADHD. We may have some people with ADHD here today. And we know that the outcomes can be very positive as people learn coping skills and the environment supports their growth and development. But we also know that the outcomes from ADHD can be quite serious. And so we're really interested in understanding what those predictors are so that we can shore up protective factors and try to mitigate the risk. And then we develop interventions to enhance developmental outcomes for individuals with ADHD, really across the lifespan. And then finally, in recent years, we've been focusing on implementing the interventions under real-world conditions to reduce some of the disparities we see in who gets diagnosed and who gets evidence-based interventions for ADHD. So the latest estimate in 2022 is that 11% of youth in America have been diagnosed with ADHD. That's a pretty incredible number, meaning that about 1 in 10 kids or several children per classroom will be diagnosed with ADHD. So this is a really common disorder and one that has touched most of our lives. And so for that reason, I think it's really important that we work very hard to make sure that information about ADHD gets out there and that we're making sure that evidence-based treatments are accessible. For those of you who aren't familiar, these are the categories of ADHD symptoms. And we do always say that when you meet one person with ADHD, you really have just met that one person with ADHD. There's a lot of variability in terms of how these symptoms are combined within any individual. And so we see that some people with ADHD have the inattentive symptoms, but not so many of the hyperactive and impulsive symptoms. Others have hyperactive impulsive symptoms, but we don't see many inattentive symptoms, and this is especially in younger kids. It may be that initially those hyperactive impulsive symptoms are most prominent until they enter school and the demands get greater, and then we see these inattentive symptoms come online. But the majority of people with ADHD do have a combination of the inattentive and hyperactive symptoms. Emotion dysregulation isn't in our diagnostic classification system just yet, but we know that individuals with ADHD have a tough time regulating both positive and negative emotions. So when they're excited, they might get really, really excited and have a hard time knowing when and how to regulate those positive emotions. And similarly, with negative emotions, we see the same thing. So sometimes some combination of emotion dysregulation and impulsivity could lead to outbursts and things like that. And we expect that in the next iteration of the diagnostic classification system, that emotion dysregulation will feature prominently in our diagnosis. Some people might have some of these symptoms, but they might not experience impairment, and so we wouldn't give a diagnosis of ADHD in those cases. People with ADHD do tend to struggle academically or occupationally, and we'll talk about that in more detail. And they also often struggle with social relationships. So beginning in childhood, we see difficulties with family dynamics, difficulties making friends and keeping friends, and then we we see difficulties in relationships with work colleagues and or romantic partners. And this can be a result of maybe not listening, not seeming to pay attention to conversations, some impulsive responding, and then those emotion dysregulation symptoms as well. Now, oftentimes with ADHD, as I mentioned at the beginning, we see a cascading of difficulties across development. So there might be other mental health difficulties that come online across development. So we see a higher likelihood of depression. And there have been a lot of hypotheses about why this might be the case. One of my former doctoral students did some work showing that emotion dysregulation mediates the association from ADHD to later depression. But if we think about the negative feedback that many individuals with ADHD get in different domains of their lives, one can imagine that can lead to low self-esteem and depression. And unfortunately, we, in some of our work, have shown that about 20% of kids with ADHD have made a suicide attempt before age 18. And so, this highlights the fact that we really do need to pay attention to ADHD. We can't sort of assume that ADHD is always going to be mild, that very serious outcomes can result. We also see substance use, higher likelihood to engage in early experimentation with alcohol and drugs, and a higher likelihood of developing a substance use disorder. And there are also a host of physical health conditions that can result from ADHD, typically related to poor self-regulation, things like obesity, high blood pressure, high cholesterol, et cetera. And combined, all of these things can lead to a 10 to 15-year reduced life expectancy. And this is not only the result of suicide, accidents, and the like, but also these health behaviors that I mentioned. Now, all of that said, it sounds like a lot of gloom and doom, but the good news is that ADHD is highly treatable. For many years, we've had many evidence-based treatments that work quite well, and one of the challenges we're facing now is how we make sure that those treatments can be accessible broadly and not just to our most resourced people. So there are indeed disparities in terms of who's diagnosed with ADHD. I always get the question, is ADHD overdiagnosed? Well, we know it's both overdiagnosed in some groups and underdiagnosed in many people who might need help. And we know that things like academic accommodations at school are often received by those kids whose families are able to advocate best for them, and oftentimes for families where English is a second language or parents might have lower levels of education, that they aren't necessarily accessing those academic accommodations that could help them to be more successful at school. So these are all things that we want to work on for the future. So I mentioned evidence-based treatments. Well, what are those? Stimulant medications, of course, work very well, and now in more recent years, there have been the development of non-stimulant alternatives, so atomoxetine, Quellbri, there are always new drugs coming on the market. And medications can work very well for about 80% of individuals who are willing to give them a try. We know that there's a lot of medication hesitation, however. There's some children and families or adults with ADHD that are just not willing to try medication because of various concerns. And oftentimes you need to try different medications before you find one that works. And there are also concerns about, some individuals feeling like the medications might dampen their enthusiasm or their sociability. And so oftentimes individuals with ADHD don't choose or don't want to continue to use their medication on a regular basis as they move into adolescence and adulthood. So this is a challenge. The other thing is, I think that most people would agree that medication for ADHD is not a magic pill. And so that we really do need to teach skills. Beginning in early childhood, many studies since the 70s and 80s have shown that behavioral interventions at home and at school can be very effective for ADHD. And so this can include things like teaching parents and teachers how to set very clear expectations, how to create a consistent level of structure and routines in the environment, to praise positive behaviors and efforts, and to use non-physical forms of discipline for serious negative behaviors. And so these strategies can work quite well, but they require a high level of consistency on the part of parents and teachers. And so sometimes follow through on these strategies can be variable. And also, it can be hard to find therapists, right? So this is a very huge reality, especially since the pandemic. Organizational skills training is also an evidence-based treatment, particularly for older children, adolescents, and adults with ADHD. So organizational skills training can include executive functioning strategies like using a prioritized to-do list and a calendar system, and organizing one's workspace, and et cetera. And this, too, takes a lot of work to be consistent. And so we know that the consistency, keeping up with it, right, even if people initiate these treatments, making these strategies part of their day-to-day routine and just really sticking to it can be a challenge. And we know that combinations of these treatments, so medication along with behavior therapy or organizational skills training, is generally the most effective treatment. But when we're talking about youth and treating youth, it's important to know that all of these evidence-based treatments rely on parents. So if you're the parent of a child with ADHD, you are, tasked with a pretty big job, right? And so parenting can be a lot of work, and so it's a little bit more when you have a child with ADHD. So even in the case of medications, you need to remember to make an appointment with the doctor, get your refills, go pick them up, and most importantly, to give the medication every morning. Right? So in the case of medication, there's some work on the part of parents. But when we talk about behavior therapy and organizational skills, parents are really scaffolding all of this. And we sometimes refer to parents as the arm of the therapist, right? The therapist might meet with a family once a week, but the parent is there every day. So much like our treatments for autism, with ADHD, we are teaching parents how to be the arm of the therapist. So one thing we know about ADHD is that it's very highly heritable, and about 80 to 85% of the variance in ADHD symptoms could be attributed to genetics. So genetics and neurobiology are established as the causes of ADHD. By no means does parenting cause ADHD, but we know that there are elements of the environment that can help kids with ADHD be more successful. And because ADHD is so heritable, we know that in many families, parents struggle with ADHD themselves. And generationally, many parents have not been diagnosed with ADHD. So they might not be aware that they have ADHD. And oftentimes when we are doing our diagnostic assessments for kids, parents might even say, wow, that sounds a lot like me. Or these questions you're asking kind of apply to me too, or to my spouse or partner. That actually rings a bell. And so that provides a perfect opportunity to talk about how we can support parents alongside their kids. What we know is that when parents and their kids both struggle with ADHD, it predicts poor child outcomes over time and poor treatment outcomes. So it can be much harder for parents to be able to implement the skills that I talked about just a moment ago, and to do that on a consistent basis when they also have ADHD. So if you're teaching parents to set up a consistent structure and routine around homework, it's going to be harder for that parent to do that on a consistent basis if they too have ADHD. So again, we're not blaming parents. We have to be really, really deliberate about saying that ADHD is not caused by parents or parenting, but we do know that helping to facilitate parents creating a certain structure in the child's environment can help them achieve those positive developmental outcomes. So we know parenting is hard, as I mentioned before. Parenting requires a lot of executive functioning. Okay, so that means that as parents, we do a lot of planning, organization, when there's, someone gets sick or a parent goes on a trip or whatever, you need to problem solve, right? And you need to be flexible. You need to remember a lot of things, and you need to, as I said, problem solve. So those are the executive functioning aspects of parenting. And if I flipped back to the symptoms of ADHD, if you map these onto the inattentive symptoms, you see that parenting requires a lot of things that are difficult for adults with ADHD. There's also the emotion regulation aspect of parenting. So when your child does something that you might find really annoying, like they're making that sound, or they're playing really loud, or they're dancing around, or doing things like that, and it really annoys you, or they are very defiant, you have to keep your cool somehow, right? And so if you're an adult with ADHD who struggles with emotion regulation, it might be harder for you to remain calm and to avoid sort of harsh or negative reactions to your child's misbehavior. So these are really the two domains of parenting that we see are most challenging when parents have ADHD themselves. And so all of our behavioral and organizational skills that we are teaching parents in our evidence-based treatments require parents to remain consistent and to create this organized environment to scaffold their child's developing executive functioning skills. We ask them to inhibit negative impulsive responses to child misbehavior in favor of planned responses, that we might encourage them to ignore some of those minor misbehaviors, or instead of yelling and spanking, to use some other form of non-physical discipline. We also work with parents on how to be most effective in collaborating with the child's pediatrician, with the child's school, even though the teachers or the school psychologist might not be meeting our child's needs the way we want them to, and we might be really, really frustrated with the school. We have to work with the parents on how to foster that collaborative relationship with the common goal of helping the child to be successful. And also, parents of children with ADHD have to schedule and keep appointments, right, and administer daily medications, as I mentioned before. And so oftentimes we get charged, right, when we miss appointments. And it doesn't matter if it's an appointment with the psychologist or the hairdresser, you will often get charged. And sometimes those providers won't be able to keep you on their caseload if you have a certain number of cancellations. So these are real concerns that families face. So in our work, we have increasingly been trying to focus on how can we support parents who have ADHD who want very badly to do their best for their kids and to help their children be as successful as possible, yet they are struggling with many of the same problems. And again, we want to do this in a supportive manner that doesn't sound or feel like we are critiquing the parents or blaming them in any way. They're simply struggling with the same kinds of problems that their child is. So we started out with a couple studies in collaboration with Children's National Medical Center in DC. And we did a study simply looking at whether you treat parents, and in this study it was just moms who have ADHD, if we treat them with stimulant medication, would that improve their parenting? And would that yield better child outcomes? And this study was done with parents of kids who are 6 to 12 years old. And so what we found is that although, as expected, the stimulants improved the mom's ADHD symptoms and her impairments in other domains, and they told us that they felt like their parenting was more consistent and that they spanked less, which is always a good thing. At the same time, when we asked collateral informants, so another parent or a grandparent, and we observed their parenting before and after they took medication, we didn't find any effects on parenting. So what we see is that although medicating parents helps their ADHD, they really still fell back into those old patterns in parenting, which isn't really surprising when you consider that the kids were 6 to 12 years old and those patterns of parenting were pretty well established at that point. So what do we do next? Well, this led us to a number of clinical decision-making questions. And as Julie mentioned, we, in our work, are always trying to answer the types of questions that will help clinicians. And I assume we have many clinicians here. So clinicians are faced with many questions. So if you're treating a family in which both a parent and child have ADHD, and you could say, well, based on that study, most families probably need both medication for the parent and a behavioral intervention focused on parenting. But the question is, do all families need that, right? Resources are limited. In many cases, these treatments cost money, and there's a lack of providers available to provide these interventions. So it would be important for us to know which parents and families need one intervention versus the other versus a combination. So what factors can help us decide which families need what treatments? And in the research world, we call these moderators. How should parent and child treatments be sequenced? Which ones do we start with? Well, we thought ideally we would want to treat parents first because then they would be in a better place to receive these interventions for their kids, and they might be able to incorporate these skills on a more consistent basis. But on the other hand, most of the time when parents call, they want treatment for their kids. Most parents are more focused on helping their kids than helping themselves. Most of the time, they put their own needs on the back burner. So how do we sequence these? And as a clinician who is going to be treating a family, which one do you start with? How do you make a decision? And then, some other questions are, are parents going to be more consistent with practicing these skills when they're medicated first? And does this yield better treatment outcomes? And with regard to younger kids, we know from some studies back in the 90s and early 2000s, and now the American Academy of Pediatrics actually recommends starting with behavioral interventions for younger kids. Yet at the same time, we know that these behavioral interventions don't work as well when a parent has ADHD. So if we treat ADHD in parents, might we be able to delay the need for medicating the kids? So these are some of the questions that guided our subsequent work. What we did was something called a SMART trial, and this is used not only in psychological research, but also in medical health research. And this was a pilot study where we randomly assigned a small sample of mothers with ADHD and their kids who are at both genetic and environmental risk. We started either by giving moms stimulant medication, titrating medication, or we started with a behavioral intervention for the parents. So at the 8-week mark, we were able to compare those two approaches. And then for families that were still struggling at that point, we would either continue with longer term of that first round of medication or first phase treatment, or we'd add the second treatment. And these are small n's because this was a pilot trial and we wanted to make sure we could do this before we embarked on a fully powered SMART. And what we found, not surprisingly consistent with our other work, is that the ADHD medication for parents helped the parents with their ADHD, really didn't show very many effects on parenting. However, the one exception was less spanking, which is not a minor finding. So less spanking is typically good, but otherwise really didn't improve other domains of parenting or child behavior. And that the behavioral intervention actually worked really well in terms of improving parenting and child behavior. And so it seemed like most parents needed combined treatment. But this was a pretty small sample size, so we didn't draw any conclusions about the ordering of those treatments. So as we were trying to figure out what to do next, there was more of a focus from the National Institute of Health and otherwise to do more sort of real-world research using real-world providers and models that can be more sustainable. So at that point, we embarked on a larger study, which we call TPAC, Treating Parents with ADHD and Their Young Children. And this is what we call a hybrid effectiveness implementation trial because we're both concerned with the efficacy of the interventions, how well they worked, but also implementation factors like how sustainable is this, how open were the families to receiving this treatment, how open were the providers, could we sustain this, could it be paid for, is this a model that could actually work even after our research funding had ended. So in this study, the main question was, does parent stimulant medication enhance the effects of a 10-week integrated behavioral parenting intervention? I'll tell you a little bit about what that involved. And our outcomes were things like parent functioning, child functioning, and parenting. So that's really, across our studies, that's what we're really interested in improving. We want the parents to feel good and to be doing well. We want the kids to be functioning at their best. And we want to do that by way of improving parenting. And so in this study, we recruited 120 families, and in recruiting these families, our initial goal was to recruit them all from an urban pediatric primary care network that served very low resource families in Washington, D.C. However, the pandemic hit just as we launched this study. So unfortunately, only about 25% of families came from these urban pediatric primary care clinics. And so we also broadened our approach to recruiting people through the electronic medical records. So the portals that all of your doctors encourage you to sign up for, we were able to recruit from there. We talked with providers across the Children's National Network as well as other local providers about the types of families that we were looking to recruit. And we also sort of trained them and talked with them about how to bring up the question of parent mental health. And we also did a variety of other community outreach activities like giving talks in the community, PTAs, CHAD groups, And we also placed Facebook ads. And then we randomized those eligible families to both groups got a 10-week integrated behavioral parent training program, but half of the parents first received a stimulant medication titration. And when we applied for this grant, we thought that it was going to be really novel, that we were using telehealth. I've heard many of these stories here the past couple days. But of course, once the pandemic hit, all treatment was pretty much delivered via telehealth. So that made access much easier for families, and it worked very well. When I keep referring to our integrated behavioral parent training intervention, what I mean by integrated is that not only did we work with them on parenting skills and strategies that have been shown to work for kids with ADHD, but we also folded in throughout the intervention a focus on the parent's own mental health. And our experience suggested that many of these parents might not have actually gotten therapy or help for themselves if it wasn't sort of folded into the context of trying to help you so that you could help your child. And so the book that I had depicted at the very beginning kind of describes those different strategies. And then we looked at outcomes at 16 and 36 weeks after they were randomized. So there were many unique aspects of this study. First of all, as I mentioned, we used this hybrid effectiveness implementation trial design. So we were looking both at whether the treatments worked, but also could they be sustained within the workflow at these various clinics and by the real-world providers that were implementing them. We embedded the study in pediatric primary care, which seemed like a really good way to kind of piggyback on the routine screening that was done. So at Children's National, every time a child presents for their annual well child check, the parents do complete checklists about the child's emotional and behavioral functioning. And so we added to that a brief screener for parent ADHD. Now that wasn't unheard of because after a new baby is born, many pediatrics offices screen for postpartum depression. So this was analogous to that. And most of the time, ADHD is actually treated by pediatricians. So pediatricians are one of the first providers that parents express their concerns about possible ADHD to. So they do the bulk of the ADHD diagnosis out there. And so, and many times pediatricians have long-lasting relationships with families. So they're in a good position to be able to broach the topic of parent mental health. And so another unique feature of our sample is that unlike our prior studies, here 25% of the participants were dads with ADHD, and 25% of the families that we treated were very low resource. And so not only were they facing things like food and housing insecurity, but also during the pandemic, these families were hit much harder. They were losing family members. They were living in, smaller spaces. Lots of challenges related to that. And many of them were essential workers that had to go out there. There was a lot of fear about going on the DC Metro because, they didn't have cars. And so lots of concerns about contamination with COVID. And so we also recruited young kids with ADHD, 3 to 8 years old, and they hadn't received medication before. So again, we were able to see, and we actually haven't run the analyses yet about whether we could delay the need for child medication, but that's certainly one of the goals of the study. And another unique feature is that our parenting intervention enveloped different evidence-based strategies for treating parent ADHD. So the same kinds of things, cognitive behavioral therapy as well as organizational skills. And I'll show you what those skills were in a second. And then we use telehealth to both titrate the parent medication and to do the behavioral intervention. And importantly, as part of this hybrid approach, we had a community advisory board that helped us design all aspects of the study. And I know that that's something that's used a lot here at the Mind Institute. So we had parents from these clinics in Southeast DC. We had pediatricians advising us. We had the behavioral health providers who are embedded in the pediatric primary care locations. And we also had the office staff that were helping us to do the parent ADHD screeners. So they all provided input on all aspects of the study. And so this is important for sustainability. If we want to develop a model that can stick, then we need to be talking with our community advisors. So the parents, as you could see here, as I mentioned before, 25% of the parents were male. So fathers, about 28% of the parents were African American, 4% Asian, about 10% Hispanic or Latino, which may not meet the sort of level of diversity that we were hoping for this study initially before the pandemic hit. But this is a huge improvement over the ADHD treatment literature, which is mostly consists of white middle to upper middle class families. And then you could see our mean family income was quite high. In DC, there's a huge range. But those 25% of families that were recruited from the clinics, actually, many of them, most of them, were receiving public assistance and were living with very limited resources. We just had a lot of families at the other end, extreme end of the income spectrum. The kids were 35% female, 65% male. So I mentioned the stakeholder participatory approach, and this is Joyce Louie, who is a junior faculty who was working with us at the time. So briefly, to talk about what our stakeholder advisory group told us, in general, they saw great value, and especially the pediatricians and behavioral health providers thought it was a great idea to integrate parent mental health with child mental health care, because many of them see a lot of the same barriers and difficulties and challenges when parents have their own untreated mental health conditions. However, the parents that were on our advisory board, the majority of whom were African American, did feel like in the community that there's been a history of negative experiences with mental health care, and as a result, a lot of mistrust and the need for a great deal of sensitivity when talking about parent mental health. Lots of concerns about, is this going to sound like you're blaming the parents? Is this going to suggest that these parents are not equipped to take good care of their kids or to do the best that they can for their kids? And so really needing to be sensitive so that the messages around parent mental health were framed as supportive instead of offensive. Another concern with this study is that there was a medication component. So even though we weren't going to medicate kids, we were going to medicate half of the parents. And so anyone who signed up for this study had to be willing to potentially be assigned to the medication condition. And although I don't have an exact number at my fingertips, we did lose a lot of families because of that concern with medication. So if we were to do this study all over again, we might start with an approach that didn't involve any medication and that involved more shared decision-making with families around the approach that they would like to take. We also, even though we had designed the study to do 100% clinic screening, the families felt very much like it would be sort of abrupt, surprising, and offensive to get a questionnaire about their own mental health in the packet, in the waiting room, without any context. And so they would much rather prefer to have those sensitive discussions with a trusted provider like the pediatrician. And so the pediatricians appreciated that, and although we're used to asking questions around whether anyone else in the family has diabetes or has had cancer, other medical conditions, there's still some concern around asking about parent mental health. And because some of these discussions tend to be longer, the pediatricians were concerned because many of them would see 25 children in their, each day in their clinics. And so they were concerned about whether they would actually have the time to have these types of sensitive discussions. And so prior to the pandemic, they could simply, do a warm handoff to the embedded behavioral providers. But since the pandemic, a lot of these behavioral providers were working hybrid schedules and weren't always there. And so that was a little bit trickier. So this is something that, that we still are grappling with, because there are a lot of structural barriers for screening parent ADHD in pediatric primary care. Not to mention that a lot of pediatricians are not as comfortable screening for parent mental health, because the question is, well, what if we find out that a parent does have ADHD? What then? What about when the study is over and we can't just hand them over to you to help? What are we going to do? Wait lists are very long. Oftentimes, primary care providers might feel less equipped to treat ADHD as opposed to other disorders like depression or anxiety. And so what do we do in those cases? And so as we think about where this research is going next, I think family medicine is probably a better setting, because family medicine physicians are comfortable treating both adults and kids and take a more family-based approach. So getting back to the sample at hand, the parents half had the inattentive presentation of ADHD, meaning that they had mostly the disorganization, forgetfulness, those types of symptoms, and about half had the combined type. And as you could see, many of the families had a past history of depression, social anxiety. I don't feel like we did as great a job as we could have assessing trauma, but this is a major issue, especially with our clinic families. But certainly we saw a lot of depression and anxiety in the parents. And we did allow them to be on a stabilized dose of an SSRI medication. And the kids, most of them were combined subtype. And many had oppositional defiant disorder. Now, these assessments that we did as part of this study, very helpful to the families, and we would give them reports. Many of them were very hesitant to share those reports with their child's school because they didn't want their kids labeled. So this is another thing that we grapple with, right? A lot of times parents are very concerned about the stigma associated with these labels, but without those labels, oftentimes they won't get the services that their child needs. So this is something that we want to continue to grapple with as we work with more diverse populations. This is a consort diagram describing what happened after screening. You could see that we screened lots and lots of families in those clinics and randomized 120. Most of them we were able to retain. But again, this was a pretty stressful time in history between the pandemic as well as the Black Lives Matter movement. There was just a lot happening. I alluded to our integrated behavioral parent training, and I'll tell you a little bit about how we combined this. The parenting skills that are integrated into most evidence-based treatments for kids with ADHD are here in this column. And then the parent skills that we weaved in are here. So kind of taking one at a time, one of the foundations of our behavioral interventions are to do special time, to have the parent do special time with the child for at least 5 minutes a day, where they're not guiding the child, they're not correcting them, they're just spending time with them, reflecting what the child's doing, being very positive, not making any demands. And along with that, we worked with parents on identifying pleasant activities for themselves to do and to try to spend some time every day doing something that they enjoy, which is very hard, right? It's hard for most of us. Many parents, especially parents of kids with neurodevelopmental disorders, might say, I don't have time for that. So we would work with them on how to figure out small things that they could do. Maybe, listening to music while they're driving or cleaning the house or doing the dishes or making dinner. Maybe it would involve things like taking a walk around the block if they were able to, or to call someone or talk with someone on the phone when they're driving home from work, or lighting a candle, or reading a book for 30 minutes as they're trying to go to bed, things like that. So trying to figure out what are some small things that you can do that are value driven, ideally. So we refer to this as behavioral activation. For some families, it was going to a church or religious services or things like that. So having them identify what's important to them and making sure that they're staying in touch with those things so that they could fill their own cup and be able to be in a better place to manage their child's needs. Similarly, all of our behavioral interventions involve consistent structure and routines. Well, what do you do if you're a parent who considers yourself spontaneous and really doesn't have a lot of structure and routines? Well, we work with parents on time management, and a big piece of this was sleep. We all know that we're cranky. We have short fuses when we don't get enough sleep, right? And so parents prioritizing their own sleep is really important. So we would work with them on developing a daily schedule, making sure they're getting enough sleep, making sure that they're scheduling their special time and their pleasant activities and all of those things. We, in behavioral interventions, work with parents on praise and rewarding their child. But oftentimes, these parents were noticing all the negative things that their kids were doing, not necessarily recognizing the child's efforts and the many things that they were doing right. And so we used strategies from cognitive therapy to help them to notice those positive things that they could then praise. We are famous for telling parents to ignore minor irritating behaviors that their child might do. But if a parent is tired and at the end of their rope, they're going to have a hard time doing that. So we work with parents on things like relaxation and mindfulness, etc. And I won't go through all of these, but another example here, as I mentioned before, is working with the schools. We work with parents on understanding that continuum from being passive all the way through assertive to aggressive. And in my experience with parents and schools, some parents are very hesitant to ask for what they need, particularly parents who might struggle with language or who might have lower levels of education. They might have a hard time asserting themselves and asking for what they need in IEP meetings and 504s and things like that. And then other parents go in there and they say, I'm going to give them a piece of my mind and I'm going to demand what my child needs. And usually that approach isn't met with a great response either. So we work with parents on that as well. So anyway, these are just a sampling of the skills. And it could be a lot, but we try to pace it at a level that works for families. And there were some of these sessions that were more optional based on what the family needed. So in our TPAC study, again, remember the question is, how can we, does adding parent medication enhance the effects of our behavioral parenting intervention? And what we see is that in both groups, regardless of which treatment arm they received, we saw improvement in the child's level of functioning. So in both conditions, we saw child improvement, but that children in the condition where the parents received medication first improved at a faster rate over time than those receiving the parenting intervention alone. So this was our primary outcome. And what we saw was that in other domains, both of the groups improved at pretty much the same rate. So actually, parents functioning improved better when the parents got medication in addition to the parenting intervention. But for these other outcomes, we saw improvement, comparable improvement in both groups, which is different than the literature showing that parents don't improve as much following behavioral interventions when they have ADHD themselves. But perhaps our integrated approach to parent training worked better than the standard parent training would. So in terms of a summary of results for the TPAC study, parents receiving parent stimulant medication in addition to the parenting intervention had children who showed faster improvements in functioning than those receiving the parenting intervention alone. And the same was true for parent functioning. And on parenting, we saw greater improvements in positive parenting and consistency reported by parents when they got the stimulant medication in addition to behavioral parenting intervention, but that other aspects of parenting improved similarly across the two groups. And so this showed that a family-based model could be implemented in urban pediatric primary care. And as I mentioned before, we really want to extend this to family medicine, and we want to also extend this in a way that doesn't require parents to have to be open to the possibility of getting medication themselves. Okay, so I'll pause there for a second and say that another element of the work that we want to do with these families is to involve some aspect of family navigation. We know that navigating the system, whether that be system to receive social services in addition to therapy and medication, or if we're talking about obtaining academic accommodations at school, this requires a lot of steps, a lot of paperwork, a lot of back and forth, which is really hard. And so we want to figure out ways to best support families who are living with fewer resources. So that's another direction that we're hoping to go. The other thing that we're always thinking about, and I know this is similar to much of the autism work that happens here at the Mind Institute, is how can we back things up and start even earlier, right? We know that the trajectory can be influenced by early caregiving, and so what do we need to understand and what do we need to do to kind of begin intervening as early as possible? And so we've done some developmental studies. We've used some data that we have access to looking at infant risk for ADHD and the importance of early caregiving. So this started with a meta-analysis that was led by my colleague Heather Joseph at the University of Pittsburgh. We identified through the literature what infant temperament characteristics were most likely to predict later ADHD, and the temperament types that emerged that were most important were activity level, not surprisingly, sustained attention, and negative emotionality. So those are the early infant and toddler temperaments that are most likely to predict later ADHD. But the important thing that we want to focus on is that this isn't entirely deterministic, right? It doesn't mean that if you have a baby or toddler with this type of temperament that they are destined to develop ADHD. So in the subsequent studies that we did, and there are 3 of them to highlight here, what we saw is that temperament interacted with the early caregiving environment to predict who showed later ADHD symptoms and the trajectory of what those ADHD symptoms look like over time. So there were 3 studies So what are we doing now? Well, we are trying to intervene with expectant mothers that have ADHD, and we call this study the MAMA study. I can't take any credit for the cute acronym because I'm terrible at that, but this is the Moms Managing ADHD study, and this is a study that I've been working on with Heather Joseph, a child psychiatrist at the University of Pittsburgh. And so we are applying those skills and strategies from our book that we typically use with parents of older kids with ADHD. And we're trying to teach a lot of those skills and strategies to expectant moms during pregnancy, and then helping them to incorporate those strategies after the child is born. For those of you who have had children, you think about what was pregnancy like? Well, there's a lot of things that you have to keep track of, right? Lots and lots of doctor's appointments. You have to eat well, not eat certain things, and eat more of other things. You're supposed to exercise. You're supposed to get enough sleep. Take those prenatal vitamins every morning. You're dealing with mommy brain, right, which can look a lot like ADHD. Once the baby is born, you're managing the baby's sleep schedule, trying to get them on somewhat of a schedule, right? But that's really hard to do, especially when they're a moving target. Things are always changing, right? They start teething and all the other things. You're trying to keep track of babies feeding. Before they come home, you're preparing your home, your nursery, or hospital bag. And there's also a lot of things that you're supposed to be avoiding, right? Like alcohol, drugs, some food, coffee, caffeine, and it can be a bit stressful, right? We like to think of pregnancy as a really happy, exciting time, but it's also pretty stressful, especially for first-time moms. Not to mention the fact that many doctors do recommend not taking ADHD medications, which there's a lot of controversy around this, and there are registry studies showing that, in fact, it might not be so harmful to take ADHD medications. There's still a lot of very conservative doctors out there who are advising not to. Okay, so then when you consider ADHD, right, we know that there's a much higher risk for postpartum depression and suicide. New moms with ADHD experience parenting stress, more partner conflict, more home chaos. And we know that kids with ADHD are at risk for all of these negative outcomes that we talked about before. So just like with the other study, we started out taking a hybrid effectiveness implementation approach. We started out talking to pregnant or new moms with ADHD to hear about their lived experience. And this is something that I think is just so incredibly valuable. We need to talk to the people we want to help, or we might completely miss the target in terms of the interventions we're developing. So I thought these particular quotes were really powerful. One mom told us, "I was told that I was no longer able to take my ADHD medication while I was pregnant. This is my second pregnancy. With the first one, the doctor just told me all these terrible things that could go wrong, but they really didn't give me any other avenues on how to manage my ADHD. I just kind of felt afraid and scared that I wouldn't be able to manage it." Okay, very powerful. A new mom with ADHD told us, "I have very bad time blindness." And this refers to kind of not sort of keeping track of time or time passing by really quickly without realizing where it went. "I will often not be sure 15 minutes or 5 hours has passed, which does not help, especially when you have a newborn and they need to eat, and you got to remember to feed them and also change their diaper and then check how much time and everything else." And another, "If my daughter's crying, she needs to eat. I can feed her and set her down and do what my son needs to do. I can bounce back and forth, but I don't remember to do everything. I'll make the grocery list, and I'll either forget the list or forget half the stuff, even though it was on the list. So part of me thrives on bouncing from task to task, but getting all the tasks totally finished never really works out. So again, I said that we adapted the other content that I talked with you about, and we also showed our community stakeholders these different skills and strategies. So this is what we came up with for our 6-session intervention. And you could see many of these look familiar from the other slide that I showed you with our work with parents of older kids. And at this point, we are launching the randomized controlled trial, but we have quotes from these moms. And as you could see, it sounds very promising. I'm really glad that the MAMA program exists. I know I was expecting my ADHD symptoms to get worse during pregnancy, but I was really not prepared for how much worse it got. I did really appreciate it and felt like I got a lot out of it. I felt like I kept telling my one sister, I feel like this is preventive care. Things that maybe I didn't think about before, but I realize how important this is, and I'm excited to put it in motion once the baby's here. I feel less anxious, less overwhelmed. I feel like I will be able to handle it. So that's self-efficacy. You could see some of these others. I feel like I had a better idea of how to get my things accomplished and take care of myself. I just felt like I was supported really throughout my pregnancy in a way I didn't expect. I just didn't expect for all of it to feel so supportive and helpful. And the different things that we talked about were so practical and really related to where I was at in my pregnancy. I think it was really helpful for me having a diagnosis of ADHD and being unmedicated for the first time in a while, having support for managing and basically adding more tools to my toolbox on how to manage those symptoms during pregnancy, and also thinking about how my mental health may be impacted by pregnancy and parenthood. So we really focus this on supporting the moms, but of course our goal longer term is to help them to create the optimal environment for their kids. We're also working on an AI-powered chatbot to help these parents through pregnancy and postpartum as well. Okay, so before I wrap up, I just want to tell you that these were just a couple of the studies that we're doing. We really do take a lifespan approach. So I told you about the MAMA study. There's a TOTS data set, which the principal investigator is Nathan Fox at the University of Maryland. We've used a lot of those longitudinal data to pinpoint risk and protective factors. We had a study in the Baltimore City high schools in which we recruited teens with ADHD, also living in poverty, who were experiencing depression symptoms, and we did a depression prevention and suicide prevention with those kids as implemented by school mental health providers. We do a lot of research with college students. We know that college is a huge transition time for kids with ADHD who are learning how to structure their days independently now in the light of less parental support and also temptations, sex, drugs, and rock and roll in college. And we're studying their substance use behavior and also have an intervention to reduce problem drinking in college kids with ADHD. And then, of course, we do a lot of work with parents who have ADHD. We also, in the service of disseminating evidence-based information, if you're interested, you could grab this QR code, and we have these little 2-minute videos depicting different tools in our toolbox, teaching online organizational and virtual learning skills, and we developed these during the pandemic. And these are available in English, Spanish, and Mandarin, and all of them come with a one-pager describing the skills. So this is very bite-sized. And so just to kind of leave you with a couple take-home points, parent ADHD is associated with child developmental and treatment outcomes and therefore should be assessed and treated. So we need to figure out how to fold this into our screening. Medication alone for parents with ADHD is rarely enough, and usually a combined approach is needed. When we try to implement ADHD treatments in real-world settings with diverse youth and families, we can reduce mental health disparities, but we need to be very deliberate and careful in terms of recruiting diverse samples and getting input from community stakeholders in order to make these treatments palpable and acceptable and sustainable. So just acknowledging collaborators and our team, and I'll leave it there and ask for questions.
You mentioned about emotional regulation.
Yes.
So how about anxiety? Because anxiety is one of the most common co-occurring conditions in ADHD,
Right.
and often it kind of mimics ADHD. I mean, there have been times where somebody suspects ADHD and then they are diagnosed with actually anxiety. So that's my first question. I will also go ahead with the second one. In the TPAC study for in the integrated parent intervention, I didn't notice mindfulness as one of the interventions, but I did notice in the MAMA study. So was there any reason why mindfulness was it a part of TPAC? And if not, was there any reason why mindfulness was not part of the study?
Yes, those are really great questions. So diagnosing adult ADHD is really, really hard because a lot of things can mimic adult ADHD, and especially for women, it's much more likely that their diagnosis will get delayed and that they will instead get diagnosed with depression, anxiety, which could actually be secondary to ADHD. And in some cases, anxiety with ADHD predicts better outcomes. So in terms of blurting things out and being anxious about getting that schoolwork in, that could actually help in terms of performance in some domains. But we know that ADHD plus anxiety can have worse social consequences and be more distressing in terms of how the individual feels. So when diagnosing, you really want to establish the developmental precedence of one type of problem versus another, and usually it's both. So we rarely see adults or even college students with ADHD that don't have at least one other co-occurring condition. It's very rare. And so the relevant parent skills that we have here, and actually it doesn't say mindfulness, but along with relaxation techniques, it should say mindfulness, because we do incorporate mindfulness. We use a few different relaxation and emotion regulation strategies. So that is part and parcel of the integrated treatment. And not all of these parent skills are specific to ADHD, right? So the time management, the organizational skills, those are more specific to ADHD, but things like, the cognitive, challenging negative thinking and the relaxation and the behavioral activation, those are really transdiagnostic treatment factors. So they help with all of them, with depression, anxiety, ADHD. So we really design this to be as broad as possible because in our experience, the parents we work with are usually struggling with one or more. And these strategies are helpful for all people, right? So even if you don't meet diagnostic threshold for anxiety, depression, or ADHD, most of us experience some symptoms, and these strategies can be helpful. So really the idea is that sort of put your oxygen mask on first, and or fill your cup so that you could be at your best to help your child.
Are these modules in your book? Is that where they are?
Yes,
okay,
yes.
That was my question.
And this is a therapist guide, so it's not geared directly toward parents. That's something we should do at some point. But this is a therapist manual.
Well, I wear both hats, so that works out. I will take it. So my second question, you had mentioned the goals of your study. You said a delay of medications. Was when you say one of this study, the goal of the delay of medication, is that forever? Is that for a certain age that you're hoping you have some more developmental age in kids that you would like to, before you medicate them? What would the goal be?
Thanks. That's a great question. Maybe I wasn't clear. So the American Academy of Pediatrics recommends behavioral interventions before medication for kids under age 6. So delaying until at least that threshold is met, which isn't always possible for more severe cases. But the challenge is that if you start with behavioral approaches, and behavioral approaches don't work as well when parents have ADHD, then you're kind of stuck, right? And so usually kids who are diagnosed earlier are more severe. And so, so this is a challenge. So we're trying to at least get them past that age 6. And this was based on the PAT study, which showed a poor stimulant response and more side effects for younger kids.
You look at like sleep studies and you look at the fragmented sleep, like you really can't control that. You can't manage it by taking chamomile tea and sleeping. You can't, maybe melatonin or something. So how do you work on that when, just the brain structure, rapid cycles through REM, faster, just because the brain, with ADHD you tend to be faster. So how do you manage that? Thank you.
Wow, you said so many powerful things. I don't even know where to start. And we know that actually, I thought I had a slide in here about how despite the genetic risk, we know that the environment can influence the severity over time and the development of co-occurring conditions. So it's really both genes and environment, and there have been adoption studies showing that controlling for biological parents' ADHD symptoms, that the quality of parenting and the adoptive parents' ADHD predicts the course of ADHD symptoms in at-risk kids. So it really is both. You also mentioned how when kids turn 18, there's lots of challenges, and this is something I talk with many people here during my visit. We are doing work with how to support parents through that transition to adulthood, and how it's really hard to know. There's no sort of playbook in terms of how you support their growing independence, but at the same time, parents don't want to see their kids experience difficulty. And so how do you balance that need for support with the need for independence? And there are lots of barriers to staying involved in their treatment. So HIPAA and FERPA, kind of control how much access you have once they turn 18 to medical records and educational records and things like that. So that's really challenging. And then the last thing you brought up was sleep. Sleep itself could be a full intervention, right? One thing that we really focus on a lot, though, is the consistency of a sleep routine, because that helps to kind of set the sleep cycle. And so going to bed really late on some nights and sleeping in isn't going to help you get caught up as much as sticking to a very consistent routine, which we know is at the heart of ADHD. So the sleep problems are really complex and could be their own intervention. It is harder to find providers who feel comfortable treating adult ADHD. There are evidence-based treatments. There are manuals actually from the same series that we published in the Oxford Treatments That Work series. There's a manual by Steve Safran, and there's another one, I think, with Mary Salanto for a different publisher. I'm not sure which publisher it's with, but Mary Guilford. Okay, so Steve Safran and Mary Salanto, and Chad's website can be helpful, and Psychology Today in terms of finding someone that might be comfortable. But it is harder to find psychiatrists too. I think that comfort levels are increasing though recently.
I'm just wondering if you've noticed any difference in therapeutic outcomes when the parent either is later diagnosed or newly diagnosed with ADHD versus have had a long-standing diagnosis, may have had some intervention in the past?
That's a great question. We haven't looked at that, and I don't know that anyone else has. Sometimes parents tell us they have more sensitivity toward their kids with ADHD when they have been diagnosed themselves, but I don't know of any studies. That's something that we could look at, for sure. Great idea.
I have a real quick question about your mama study. Do you have plans to follow the children of
Oh,
those
yes.
mamas?
Absolutely,
And
yes.
what does that look like for you, for your team?
Yeah, so Heather Joseph has other studies with pregnant women without an intervention component, and they've followed the kids and are continuing to follow the kids, and they've found that the kids have more difficult temperament, and there's more home chaos, and lots of things that that sort of led us to our intervention. But when we are able to fully study this intervention in a fully powered randomized controlled trial, we hope to follow them for at least a year or longer. It's just a challenging funding environment right now, so hopefully we could get funded for that.
And just one more add to that. What about the plans for following the children?
Yes, yes, we do. Yeah, the ultimate goal in all these studies is not to help mom, to help her parenting, and to help through the parenting to be able to produce better outcomes in the child.
Did you see any significant dropout rates from the medication condition for side effects, for medication side effects?
Not too bad. No, the side effect, well, so some people who might have been initially sensitive and hesitant to take medication, some of those folks were very sensitive to noticing side effects. The way we describe it is it's just like allergy pills, right? Some people do better with Allegra, some people like Claritin, some people do better with Xyzal or Zyrtec, and so ADHD medications are the same way. So we had the possibility of either going down on the dose if they notice side effects or switching to a different stimulant. Or a non-stimulant, but that didn't come up as much. Usually these medications are pretty well tolerated, and we took a step-by-step approach to titration.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.